Welcome, everyone. I'm Bill Brandenburg, a second-year medical student at Colorado. Thank you for coming tonight. I really appreciate it. I would like to thank the Arthur N. Roop Foundation for sponsoring this event, along with the University of Colorado and the Benjamin Rush Institute. I'd like to welcome all the CU students here tonight. Where are we at? Thank you so much for participating. I'd like to mention the out-of-towners from the Benjamin Rush Institute conference. Can we get some hands up? Yeah. Thank you so much for coming. So hopefully we have a lot of fun tonight, right? So I, along with Miles Tampson, run an organization called Benjamin Rush Institute, and we're the Colorado chapter. Benjamin Rush was one of 4 physicians who originally signed the 5 physicians who originally signed the Declaration of Independence. I think that says a lot. I think since the nation's birth, doctors and healthcare people have been involved in politics, and I think it's important that we continue to do so. So I really thank all of you for showing up and participating tonight. It means a lot. Without any further ado, I'd like to introduce our debaters and our mediator. So right here we have Dr. Michael Victoroff. He's board certified in family medicine. He's the CEO of Lynx Care. He's also boarded in clinical informatics, and he has a fellowship in bioethics. Here on our left, we have Dr. Gary VanderArk. He is a retired neurosurgeon. He's on the faculty here at CU. He's our only CU guy here, so we welcome him and thank him. He is president of Doctors Care, as well as president of the Colorado Coalition for the Medically Underserved. Over here on our right, we have Dr. Jill Vecchio. She is a local Denver radiologist, also has a fellowship in women's imaging. She's a healthcare fellow at the Centennial Institute, and she also runs a radio show local here in Denver called The Heart of the Matter. Finally, here on our right, we have Dr. Todd Fredericks. He is a family medicine specialist, and he's also an assistant professor of family medicine at the University of Ohio.
Ohio University.
Oh, pardon me.
I'm sending you a Rufus doll.
He's a colonel in the United States military, so whoops. And he's had multiple.
Look for a drone.
Multiple deployments to Iraq to complicate the matter. Anyway, so I named a small percentage of the wonderful things these guys have. They have excellent resumes that extend much further than what I could say in a reasonable amount of time. So I thank them all so much for coming. At this time, I would like to introduce our mediator, Dr. John Bender. He is a family medicine specialist, CEO of Miramont Family Medicine. He's the president of the Colorado Medical Society, and he spent 13 years serving in the Army and Navy as a physician. So we have a wonderful group tonight. Thank you so much. At the end, I'm going to be quickly passing around a survey, the same kind of survey that you did when you came in with just a tick mark just to see how opinions may have changed. Okay? Sound good? Should we get started? Yeah. Okay, great. Thank you. Dr. Bender.
Thank you, Bill, for that wonderful introduction. I'd like to thank each and every one of you for being here this evening. I am John Bender, and I'm your moderator. I'd also like to acknowledge the Arthur N. Roop Foundation for providing the funding to be here this evening. And also, again, just a shout out to the enthusiastic staff and students affiliated with the Benjamin Rush Institute that have brought this event here to Denver this evening. The resolution for this debate is the Independent Payment Advisory Board. Is the IPAB the way to control Medicare spending? And so hopefully the debate will address the IPAB's effects on patients, physicians, on innovation, and on our country. We have 2 debaters who will explain why their answer to this question is yes, and we have 2 debaters who will explain why their answer to this question is no. In order to maximize a free flow of discussion, we're going to diverge a little bit from our Oxford-style debate. Each debater will be introduced, which we've already done, but we will allow each of them 5 minutes for an opening statement here shortly. And then in the next 10 minutes after that, I will have a short moderator-led session to sort of get the debating juices flowing. And then we will go to open mic, and we'll allow the audience to bring their questions. And I just ask that if you ask a question, that it be a true question and not a 20-minute comment followed by a question in 6 parts. You know, just ask one question, limit it to 30 seconds or so, in fairness to everyone else here this evening. And then I would ask our debate panel to give a response to the audience-initiated questions of approximately 2 minutes, again, so that we can share the air. This evening, we do have a vote, and did everyone get a ballot and was able to vote this evening? So we are going to repeat the vote at the end of the debates to see if there was any change in people's perceptions, or if anyone was persuaded through the course of the process. So why don't we start with just a brief introduction about what the IPAB is. And I wanted to be neutral, so I went to Wikipedia, which is, I think is neutral. Sometimes there's some editing. But the Independent Payment Advisory Board is a 15-member United States government agency that was created in 2010 under Sections 3403 and 10320 of the Patient Protection and Affordable Care Act, or PPAC, or Obamacare, some of the other synonyms for that body of law. Its task was to achieve savings in Medicare without affecting coverage equality. And so under previous and current law, changes to Medicare payment rates and program rules are now recommended by the Medicare Payment Advisory Committee, but they require an act of Congress to take effect. And in the new system, the IPAB has the authority to make changes to Medicare rates in the program, and Congress can overrule the agency's decisions, but it can only do so through a supermajority vote. And so this is a significant change in how it's been done in the past. And so starting in 2013, Health and Human Services has to collect some data to provide to the 15-member IPAB to tell them what the expected costs are going to be for 2014 and beyond. And then if the projection exceeds a certain target growth rate, then IPAB has to develop a proposal to reduce Medicare spending. And then it has to be done within a certain amount of time. And if the board doesn't take action, then Health and Human Services Secretary, who's currently Kathleen Sebelius, would have to do it instead. So that either way, the idea is that these target rates won't be exceeded. So with that introduction, I'm going to start over here to my right with Dr. Jill Vecchio. And Dr. Jill Vecchio, if you could take 5 minutes of this time to give your opening remarks.
Hi, everybody. Thank you so much for coming. I know what it was like as a medical student, and in fact, there isn't just one CU representative. I went to CU. I was a medical student here. We didn't have this great auditorium, but it was a great, great education, and I did my radiology residency and my women's imaging fellowship here also, so I'm an alum. And just so I wouldn't feel so old, I got braces a month ago, so bear with me. This is just painful. You probably had them all when you were in junior high, so I'm regressing. I remember when we had, the old medical school had this great quad, and there were all these gorgeous old buildings around it, and that's where we had our graduation. It was a perfect May Day. It was just gorgeous, and we stood up at the very end and gave the Hippocratic Oath. Do you still do that Hippocratic Oath, everybody? And we couldn't graduate without doing it from here at that time. So I'm just going to read a couple of parts of the Hippocratic Oath, just to kind of keep that in your mind for our discussion tonight, because what we really want to do is have an interaction and just a discussion, and let's just put the ideas out there. Part of it, I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. All that may come to my knowledge in the exercise of my profession or in daily commerce with men, which ought not to be spread abroad, I will keep secret and will never reveal. If I keep this oath faithfully, may I enjoy my life and practice my art, respected by all humanity and in all times. But if I swerve from it or violate it, may the reverse be my life. This was not just something I said on some day. It's something that all of us will say, and it's the most important thing we'll say as physicians, in my opinion. The Independent Payment Advisory Board is going to change how we view our Hippocratic Oath in some really important ways, in my opinion. The Independent Payment Advisory Board is set up to bypass Congress, to bypass 1/3 of the checks and balances of our Constitution laid forth for the operation of our government. So we're giving up an important part, as not just physicians, but as Americans, a part of our control over the way our government works. The Independent Payment Advisory Board, unelected officials, and Congress, let's talk about how Congress can use that as a politician, right? Anybody a politician in here? Yeah, well, we have one. But anyway, she's a city council and she's really a good politician. But a politician is going to use this Independent Payment Advisory Board to say, well, I don't want to face my electors, the people that vote for me. I don't want to risk my position in office or my ability to get reelected by cutting services to patients. And understand that by cutting reimbursement, you cut the incentives for physicians to provide those services, and therefore less of those services will be provided to our patients. So you are cutting services indirectly through the Independent Payment Advisory Board. A congressman right now, the reason the Medicare costs are out of control and sustainable growth rate hasn't, been passed, it's just been kicked down the road, is because congressmen are afraid that the electorate isn't going to like what happens because of that. And there's a good reason. It's supposed to be that way. As Americans, as physicians, we're supposed to have a voice in our government. If we turn this over to the Independent Payment Advisory Board, a group of unelected officials, our congressmen are going to stand back and go, I didn't have anything to do with those cuts. You can still vote for me because I really didn't. I was powerless to do anything about this. The Independent Payment Advisory Board can pretty much do what they want, and they're not going to suffer any electorate repercussions. So that's taking our voice out of our healthcare decisions and the decisions that our patients should be making. So think about that. Understand also that we as physicians make decisions based on what is best for our individual patients. Government makes decisions based on populations and based on studies and numbers and polls. That's pretty scary to think that all of a sudden our options as physicians will be determined based on what's best for society as a whole, what's best for a population of people, rather than what's best for the patient that's sitting across from me in my biopsy suite. Okay? Think about those things, and let's just open the discussion when we're ready. Thank you.
Thank you, Dr. Vecchio. And now we'll hear opening remarks from Dr. Todd Frederick. You have 5 minutes.
I want to thank the Benjamin Rush Institute and the University of Colorado for the opportunity to participate. Michael, Gary, Jill for participating. My thoughts are my own. They don't reflect my institution's official policy or that of the government or any agency that I'm associated with. I have no vested financial interest in anything I'm going to discuss. Tonight, you're likely to see the division of this nation in full effect. And again, this isn't pejorative against the two debaters here. This is a general concept about our nation as a whole. We have two competing and very likely contentious philosophies that purport to have the same goal of helping those in need. That's what we're here for. They're divided because of the contentiousness of the last century of political discourse in our country, because of vested interests, and because of the nature of man's desire to be free or to be ruled, a concept alluded to by Jefferson's comments about the tree of liberty. My side believes in personal liberty, personal property, and the free market to achieve ends for healthcare that is achieved with your smartphone, the private space industry, and all of the amazing innovations that are now scaled to the point where anybody can afford them. My side sees the IPAB sections of the PPACA as being 8,200 plus words long, by itself exceeding the word count of the entire U.S. Constitution and all amendments. What could possibly go wrong with that? My side looks at the data like the Talbot and Biker's papers on the Oregon Health Experiment and Mark Freiberg's paper in the Patient-Centered Medical Home that appeared in JAMA this week, and objectively states, we told you this would happen. My side that understands that money is fungible, that the CBO is always optimistic until it is no longer optimistic, and that we are deeply concerned with the national debt rapidly approaching 200% of GDP. My side concerns itself with patient autonomy and the sanctity of a physician and patient working through challenges without interference from a distant 15-person oligarchy or single-person tyranny who desires to micromanage that relationship from, say, in Denver's case, 1,600 miles away. My side believes that in a nation of 317 million people who span all colors and creeds, that the key to remaining unified as a nation is for central government to observe Occam's razor and keep things very simple. My side is deeply concerned about the blurring of executive and legislative powers and its effect of working against exactly what the framers understood was necessary to keep this whole thing from fragmenting under the massive weight of bureaucracy and human suffering like the then unknown Soviet Union did with only 240 million people. My side laments the fact that we have not had a truly free market in healthcare for most of our memories. We believe in price transparency, the act of simplicating and adding lightness, and reducing the absurd overheads associated with medicine. We believe that best government policy is shaped as locally as possible. The Councilwoman will associate with that, and as accountable as possible to the people it's supposed to serve. We believe in many sizes available to all. We believe in the smartphone moment for medicine, where anybody can get their blood work done for a few bucks, their medication for 3 months for the price of a couple of lattes, and see their physician for a tank of gas and have all the information at their own fingertips so they can make their own decisions. We don't believe in scaring old people or the indigent poor, but rather the inherent moral responsibility we have as individuals to help those around us and not fob it off to distant, faceless micromanagers. This is the side of liberty and life and happiness. The other side frequently believes something else. They want to ignore the history of price controls and failures of plutocracies in achieving the best of what is good in civilization. They want to implement unelected and unaccountable people, a board that comprises just 0.0000047% of the population to mandate for some of our most vulnerable policy that is doomed to fail to even launch. They want to divorce, through IPAB supermajority requirements, the founders' intended protections against contrived legislation created in a state of fear that we must first pass in order to find out what's in it. They want to take away from us the oversight of the very elected government that we sent to Washington to serve our interests and protect us from imperial designs. They believe that the state supersedes the individual. They believe that the paper degree confers operational competency. They believe that it is passe and impossible to believe that the average American can possibly make informed choices with their physician about what they actually want and need without someone else intervening. They believe in the need for big government to solve simple problems. They have a rosy view of floating currencies and failed programs like the war on poverty. They believe that they can somehow engineer fiscal savings out of a cabal that cannot actually shape the bulk of costs of a program it's designed to help, but it can reduce compensation to providers and thus limit the access to the vulnerable through market forces. Until, of course, that fails, and then the Department of Health and Human Services must then nationalize all health care, as the IPAB is allowed to do, and all 317 million of us will be forced into a one-size-fits-all, and everything about us will be mandated to be known. They have the audacity to then to tell the victims of their legislation their former happiness was based upon substandard plans and essentially shut up and take the pill. By basic definition, this is not a belief in personal liberty, life, or the pursuit of happiness. That's it. Liberty, a demand for freedom and transparency, or more wonks and good idea fairies giving us painful empty promises and a failed painkiller. Will the IPAB control costs? Who knows? We haven't felt its impact yet. The CBO projections suggest it's going to be a wash. I can assure you, however, that in the end we will all regret forfeiting our liberty for what we perceive as possible security.
Thank you so much. We'll now hear from Dr. Michael Victoroff. You have 5 minutes.
We're going to change place, if that's okay with you.
Okay, that would be fine. Why don't we hear from Dr. Gary VanderArk first then?
All right, thank you. Why on earth do we need this IPAB anyway? That's just going to throw away our freedom? After all, we have the best healthcare system in the world here, don't we? Well, World Health Organization says we rank 37th. Well, we rank first in one thing, spending. How about, I keep pressing the wrong one. What does the Commonwealth Fund say about health care in the United States? They looked at 42 indicators and gave us a rating of 63%. That was flunking. They concluded that if we improved our performance, we'd save 150,000 lives and $100 billion annually. What about the Institute of Medicine? They say 20,000 people in this country die every year because we do not have health insurance for everyone. That's one person every 12 minutes. Wow. Well, we do rank number one in one thing. Yes. What do we get for $2.8 trillion? That's a stack of dollar bills that would reach 3/4 of the way to the moon. We spend more than $8,800 for every man, woman, and child in the United States for health care. But those on Medicare cost a lot more, of course. $11,792 per year. 50% of everything we spend goes for 3% of the patients. And if your parents turn 65 this year, they will spend $350,000 on health care before they die. 1/3 of all the money we spend on health care doesn't make any difference. Wow. What do we do? Unnecessary services, inefficiency delivered services, excessive administrative costs. Wow. Institute of Medicine lists all these things. Why is there so much waste in health care? Well, we don't pay any attention to clinical guidelines. There's so much variation in intensity of care. We have limited adoption of information technology, on and on and on and on. Honest. We've got to do something. We've got to change things, folks. Expenses are totally out of control. Family of four now spends more than $15,000. That's almost 1/4 of their income for their health insurance. By 2020, it'll be up to 46% of a family's income. That's not sustainable. If it hadn't been for the ACA, Medicare would have gone broke by 2016. Medicare, 48 million people, 40 million old people, 8 million disabled people, 87% have one chronic disease, half have 3 or more, 21% have to be hospitalized in any given year, and 10,000 patients have their 65th birthday every day of the year. This is not sustainable, folks. $550 billion we spend now for Medicare. Wow, this isn't going to last, okay? We have got to do something different. And what better way could we do than have 15 super experts on healthcare help us to do the right thing? Now, wait a minute. Would you really rather have Congress making those decisions? Have you checked out the approval rating of the American people for people in Congress? Does Congress need any help in this regard? They don't even listen to MedPAC now. We've got to do something that works better than MedPAC. We have to change our system. Thank you.
Thank you, Dr. VanderArk. And now we'll hear from Dr. Michael Victorov. You have 5 minutes.
Okay, is IPAB the way to control Medicare spending? Is smoking cessation the way to cure cancer? No, it's not, but it may be on the way, and that's what I think about IPAB. Since it doesn't exist yet, all it is a Rorschach for our opinions, and you'll hear mine here now. Economics is the study of human motivation. It is also the discipline invented to make astrology look good. 2 ethical frameworks govern healthcare. One is a mercantile ethic, which is fundamentally substantive and acquisitive. The other is a medical ethic, which is fundamentally humanitarian and altruistic. The mercantile ethic is the brickwork of civilization. The medical ethic, a humanitarian ethic, is the mortar, compass, and square of civilization. They are as incompatible as oil and water, but you can put them in the same vessel. Ethical medicine supports itself through the means of commerce without adopting the ways of commerce. Our current healthcare system payment structure is inherently unethical. It needs to be repointed, not overthrown, but needs to be retasked. When medical agencies, organizations, institutions adhere to the medical ethic, it means they're going to refrain from acting in a way that would be immoral if a doctor acted that way. So that would be the ethic we want to ask of our institutions. This means they forsake certain tools and methods and subject themselves to constraints that would severely disadvantage them in a mercantile world. Nevertheless, that's what you do when you sign up to be a medical institution. The United States does not have a healthcare system. What we have is a healthcare ecology. A system operates according to a unifying set of rules and goals. It has internal homeostasis. It's like an organism with feedback functions to keep it from chaos and destroying itself. An ecology has no governing principle. It's large enough so that conflicting interests among the elements of it can usually be balanced. Even the hostile ones trying to eat each other can survive for a long time, but many ecologies do destroy themselves, and nobody cares. A system can be stable for long periods. It can improve itself. It cannot evolve. An ecology is never stable. It always self-destructs, but it can evolve. And so the IPAB, if it's going to work properly, might fill 3 roles that would make us more like a system and less like an ecology. Role 1 would be police. The quality of a society is defined by the quality of its justice, and usually measure that by looking at the police. You want to look at a bad society, you're going to see bad police. Likewise, the opposite, make your own conclusions. The U.S. healthcare ecology has already many kinds of policing functions inside it, but the ones that monitor costs are confused, ineffectual, and sabotaged by incoherent rules and guidance. Good police would be useful. It'd be nice if the IPAB did that. I don't know. We'll see. Number 2, medical director. A medical director serves as the conscience of an organization to monitor, steer it according to the principles of the medical ethic. I've been the medical director of large organizations. It's a horrible job. You know, everyone kills you. The ecology needs more ethical guardians inside its administrative management structures. The IPAB could fulfill, could fulfill the job of medical director. Number 3, a scout. A scout explores ahead of the caravan to mark better paths and warn about dead ends and disasters. The way they wrote the ACA is that the IPAB stays in the scout role. It actually stays in the role of an airbag in your steering wheel. You only see it if we run into something. So it could be that we'll meet all of the threshold requirements of economics, and the IPAB will never pop out. Don't hold your breath. It's gonna happen. The problem is that it's not been given the authority to intervene definitively. All they've allowed it to do is to monkey with doctor payment structure. It can't get into hospitals, which are the big game. These are the major predators in the healthcare ecology of the hospitals. Doctors are squirrels and possums. But it's not pointless to mess with doctors, because the docs of the modern era have become hypersensitive to mercantile signals, and that needs to be rebalanced. The problem with physician payment system is not charges and payments, but physician decision making. It's possible that an intelligent IPAB could get in there and fiddle with it. Tinkering with payment formulas is like treating pneumonia with cough syrup. It makes you feel better, it doesn't really help. Attacking the payment structure, however, would be to attack the abscess in the lungs of the healthcare economy. The root of the problem is the pay-for-procedure system, which as an end in itself is the downfall of hospitals and all of that. The IPAB should be thought of as a clinical trial, and we'll find out whether or not it has a net effect that's beneficial or painful. But the only way we're going to be able to impact the corrupt system that we're a part of now is to start trying some stronger medicine.
Thank you very much. So now we will roll into our moderator-led session, and how we'll conduct this is we'll take about 10 minutes, and we're a little bit ahead on time, so we're going to try to continue there. That was my timer telling me to get started. And so I'm going to first direct a question to Doctors Vecchio and Frederick, and in fairness to both sides, they were not provided the questions ahead of time. And so
42.
and so what we'll do is we'll allow Dr. Vecchio and Dr. Frederick to take 3 minutes to respond, and then we will hear a counter response from Dr. Victoroff and VanderArk. And then I will turn the tables and ask a spirited question of Dr. Victoroff and VanderArk. They'll have 3 minutes to respond, and then we will turn the table back to Dr. Frederick and Dr. Vecchio. So starting with Dr. Frederick and Dr. Vecchio, we've heard some concerns about out-of-control healthcare spending. Economist Valerie Ramey at the University of California, San Diego, has calculated that if the United States were spending 11% of our GDP, or gross domestic product, on healthcare, the way that Canada and other developed nations around the world do, that we would save about $950 billion per year in waste. And if we did that for 15 years, arguably that would be the sum amount that we owe the Chinese, which, by the way, does have to be paid back. And so looking at other independent groups such as the Supreme Court, which is independent from Congress, or the Federal Reserve, which arguably maybe helped prevent Black Monday in the 80s from being a second Great Depression, or the 2008 housing market bubble and derivatives excess be a third Great Depression. Why would we not want to set up another proud tradition of an independent body that could usher in some healthcare cost containment?
Do you want to take that?
Yeah, I can take that. Could I have a show of hands of who here thinks the government spends our money wisely? Just a show of hands. Yeah, it's pretty lonely. Charlotte, you should know better. So the idea that in my opinion, if you want to only go down to 11% of GDP, take healthcare out of the role of the government altogether. Put it back in the private sector. Put it, send it down to the states where it belongs. It's according to the 10th Amendment of the Constitution. It's not the government's job anyway to even be involved in healthcare. Now, I understand that, the Medicare, the dollars are already there, and Medicaid, but they can block grant things. The government has proven that they don't know how to spend our money wisely. They don't know how to manage our money wisely. The Medicare Trust Fund is empty. It's nothing but a bunch of IOUs, because the minute that money started rolling in after Medicare was passed in 1965, everybody started paying in, and all the politicians in Washington saw this big pile of money just sitting there, just waiting to be spent, like a nickel burning a hole in their pocket, and they spent it. Over time, they spent all that money. Now, do we really think that they can solve this problem? It's like putting new tires on a Gremlin. It's like you can't, the government has been responsible. They fix prices in healthcare, and I don't have time to go into exactly how that all works, but through Medicare and the prices set on Medicare, when we contract with a private payer, we contract for a multiplier of Medicare for our reimbursement, and that's always higher than Medicare, almost always higher than Medicare, because they know that we either break even or lose money on Medicare, and we lose money almost every single time on Medicaid. So everybody with private insurance is supplementing people on Medicare and Medicaid because the government doesn't reimburse high enough to cover our costs. Why doesn't it cover our costs? Because of all the regulation and the coding requirements that take up about, the cost is probably 40% of our overhead in a private physician's office. So the government regulations and reimbursement and coding requirements are huge drivers in the problems with healthcare. This is all government created. When government has created that much of a problem, granted, the system is a mess. It's a mess. Now, I'm not saying go back to what we had before. It's going to take an enema, right, or manual disimpaction at this point. So the answer is not to look to government to fix it when it's government that's created it. And all they're doing with the IPAB is adding another layer of bureaucracy. What, $10 million, $15 million for a 15-member advisory board? Wow, I want that paycheck. Well, I mean, it doesn't make any sense to look to government to solve these problems when it really should be a state's issue, a state's rights issue. Multiple states already have started their own experiments on, some of them have done single payer, some have done health savings accounts and tried to privatize Medicaid, although that was interrupted because of Obamacare passing. So we didn't get to see what the results of that were. But it makes more sense to me to have every state have 50 experiments in what works best for healthcare for that population of people. Iowa's going to need something different than New York City. So let the states block grant them money from the federal government. They're going to spend that money anyway. Just send that chunk of money to the states and let them figure out, and let the American ingenuity and creativity figure out how best to spend that money, how best to take care of their own people. It doesn't make sense to plan for a federal government to make a decision that will work for everyone.
Thank you, Dr. Vecchio. And now a response from Dr. VanderArk and Frederick.
Dr. Vecchio would have us get the government out of medicine. Excuse me, that was her criticism of IPAB, is that they're not supervised by the government. Now she's contradicted her first argument. IPAB is an independent group of healthcare experts, and they don't have to have their decisions endorsed by Congress. So we're doing something to take a step away from government-controlled medicine.
That's it? All right. So let's see. Don't let the thing about the $15 million slide by you. The IPAB is paid $165,000 each one. That's not enough to live in Washington. I wouldn't do it. They're doing that to keep them independent, however, and the rule is you can't have another job at the same time while you're on the IPAB. So that means that just like in the military, you have to spend your entire career there looking for what you're going to be doing afterward, and talking to lobbyists. So that has some problems attached to it. Nevertheless, independent, that's true. There are some things the government definitely does better. You wouldn't want your fire department paid by the fire, right? Suppose we said, we will pay you by the fire, bigger fires get paid more fires, more money, I mean, it just doesn't work. There's all kinds of things you don't want to privatize, and healthcare is one of them. If you look around the world and you see, I don't know, pick any country where healthcare really is something sold by oligarchs, the highest bidders, you wouldn't want to be a part of that. So there are reasons for regulation. I wouldn't want to have a drug industry without FDA. I wouldn't want to have street lights without somebody agreeing that, red means go, or which I don't know what we're using these days. But Georgia's different, and Texas, my God, it's anything. So there's a reason to coordinate some stuff, and the IPAB is not a coordinating agency. It's supposed to be something smarter, theoretically. Like I said, the airbag in the system. It's supposed to be clever enough guys that will start telling Congress, who's entirely political, and the one thing I'm sure that we're going to agree about is that the politicization of certain kinds of things, like whether we're going to teach calculus in high school, that shouldn't be something left to the government. Down with school boards, get rid of that. There's some things got to be better. I'd like to see an IPAB for schools. We'll do that next week. But let's please understand that there are some things for which there's objective data, and we should have data-based policy about how you make some medical decisions. If the IPAB worked right and it isn't, corrupted in the various ways that it could be, then it would fulfill one of those governing roles that the government needs to have if it's going to get out of healthcare instead of get into it.
Excellent. Thank you, Dr. Victoroff. So now I will direct my attention again to Dr. Victoroff and Dr. VanderArk. I will ask you.
Well, there's no response to that?
Well, we're asking a new question.
Oh, okay.
Yeah,
There's some, we're just getting some substantive errors with some of the comments.
One question back. I mean, we could, it's just we'll cut into our audience time.
Track it.
So hopefully we'll still have. So my question will be directed to Dr. Victoroff and Dr. VanderArk. You'll have 3 minutes to respond. Again, they were not provided this question beforehand, and then Dr. Frederick and Dr. Vecchio will have an additional 3 minutes to give a response. So the American Medical Association, which is widely held to be representative of American physicians, on its website calls the IPAB one of the most controversial pieces of the Affordable Care Act. It cites its lack of flexibility and notes that because of some serious concerns, the American Medical Association publicly opposes the IPAB and has supported its repeal. In February of 2012, the American Medical Association drafted a letter that was sent to the House Energy and Commerce Committee asking for legislation to be repealed. In that letter, then AMA President Peter Carmel, who just preceded our own, Colorado's own Jeremy Lazarus, said that seniors and military families rely on Medicare and TRICARE. They're already dealing with instability caused by a broken physician payment formula that Congress is struggling to eliminate, a reference to the SGR. We've made it clear to Congress that the IPAB will be another arbitrary system that will cause the same kind of dangerous cuts. What would you tell the AMA in response to their position, and why would you, or how do you explain the fact that such a representative body has a position so different from your own?
Okay, I'll start. You get the second half. Disclosure, I'm a member of the AMA. Disclosure, the AMA is not representative. The AMA should be retitled the Association of Private Practice Procedural-Based Physicians Who Want to Get Fee-for-Service. The AMA does not in any way speak for the majority of doctors, although it's extremely valuable in a million ways, but not about this. The AMA is responsible for creating the worst problem in healthcare payment in the world, which was the CPT coding system on which we sell procedures like the Sharper Image Catalog, and the burlesque of all ludicrosities. Is there a word? There's a noun.
Not with my braces, I can't say that.
I would say, you say, anyway, which would be the E&M codes, that are the attempt to codify the way that we do cognitive services. So the AMA, as far as I'm concerned, is disqualified to speak on this subject. Plus, if you read their article, which I did in preparation for this, they have a page on the IPAB in which they basically misunderstand the whole thing. It's nonsense. Now you say something.
Yeah. Okay, 17% of all physicians in the United States belong to the AMA. But it's not just the AMA. Almost every organization of physicians has come out condemning the IPAB. I think that's unfortunate and does reflect a lot of misunderstanding. At the present time, we have MedPAC. We have to look at the history of MedPAC in order to know what's going to happen with IPAB. MedPAC makes recommendations to Congress. Congress fails to act on 50% of the things that they ask for. IPAB can't be that way. They need to have more clout, and it has to be by people who understand how healthcare works. People in Congress don't.
Excellent. Your response?
Can you repeat the question for me?
Basically, the background information was the American Medical Association has taken a public position against the IPAB, and the question was how we're able to reconcile as physicians a position different than that, recognizing that the AMA has some legitimacy in representing physicians nationally.
Yeah, I don't think the AMA has legitimacy. Okay, period. They have a deep conflict of interest. Michael and I would agree on this. They have a deep conflict of interest with the ICD-9 codes. They should have no business with that stuff. I know the patient has otitis media. They know they have an earache. Why do I have to spend money working for an insurance company to tell them a code number to get reimbursed? Okay, that goes to the issue that I want to discuss, this transparency. And this is part of the problem with the fundamental flaws of the IPAB. First of all, it subverts the Constitution, right? Congress has a very narrow window to withdraw the IPAB if it proves ineffective, and after that, it cannot be reversed. Never in history has a Congress been bound by a previous Congress's actions. It's not constitutional. And we're either in national laws or we're not. Now, you guys in Colorado are trying to experiment with that, right? People in Greeley, Colorado seem to be the only people that think federal law stands. The rest of you guys want to have dope. Now, I'm agreement with the idea of federalism. I believe in that fundamentally. This is an issue about dope. It's about, are we a nation of laws and how do we proceed? Okay, we either have a U.S. Constitution and we follow it that protects all of us, or we discard it and we become something else. And let's get away from the politicization of the IPAB and let's go to the politicization of the IPAB. How's the IPAB appointed? It's appointed by the House Majority Leader, the Senate President, the House Minority Leader, the Senate Minority Leader, and the President. Now, you're telling me that's not going to be a political appointment? Yeah. And you'll forgive me for wanting to believe in the smartest people in the room. I went through Iraq. I'm watching Afghanistan. We got the smartest people in the room running those shows. How's that working for us? Now, I don't mean to be petulant, okay? But I'm a constitutionalist, and I believe we're a nation of laws. And the only way we hold this little experiment together is if we all agree on the common, simple things that bind us as Americans. And when we depart from that, and we put in groups of people that cannot be removed and cannot be superseded and require supermajorities of Congress plus a presidential approval to actually get something changed, we've subverted the very essence of what we are as a country. It's very disturbing. By the way, I'm a reservist. I would agree with a lot of military expenditures, okay? I think we spend too much money on the military given our national strategies, but that's, again, I'm speaking personally. I will follow the president wherever he orders me to go. Transparency is a huge thing, not talked about with the IPAB. They don't do anything for pricing transparency. They don't tell us what things cost. There's no mandate to do that. Fundamentally, $15 million. They are senior executive service appointees. They make about $165,000 a year, but they got $15 million for this panel of experts. It shows you what government does. If I had just $3 million and 15 super experts, I could have a heck of a think tank. Why do they need $15 million? Because this is the inherent inefficiency of our government at work. And so, I mean, that's what I got to say about that. We do agree on a lot of those principles. I just don't think the IPAB does it, right?
Maybe we could split it. Like if you and I just applied, we could, I'd take it.
You take this SES salary? Yeah. I don't want to live in D.C. That's the district of corruption as far as I'm concerned.
You're right. Sorry.
Well, that concludes our moderator-led section. And now we're going to move into our live audience portion of our discussion. And so I think to handle this, do we have microphones? And where are my microphones at?
We got both here.
Okay, so we have.
You didn't tell me they got microphones.
Moments to get these set up.
That's not fair.
Just for order of precedence.
So they don't throw them.
Why don't I alternate between the two of you, and I'll leave it to you to decide who's next in line based on the hands that you see go up. And we will start. If you have a question. Okay, so I'll repeat that. So what we would like is for people to form a line either to my right or to my left with Warren or Miles, and then we will go from there. So if you have a question, please come to the microphone at this time. I'm going to refer to Warren as microphone 1. I'll refer to Miles as microphone number 2, and we'll alternate back and forth. Microphone number 1, your question for the panel.
Yeah, thanks. Thank you, everyone, for coming. This has been a wonderful discussion so far. My question is for Dr. Vecchio. In your opening statement, you said that the IPAB is going to reduce services for Americans. Do you think that not enough healthcare service and not enough healthcare utilization is really the problem with our healthcare system?
Oh, I did not say that underutilization was happening. We're overutilizing our healthcare. Let me give you an example of how some of this works with the reimbursement. I'll give you the example that we're dealing with right now. Tomosynthesis, 3D mammography. Have you all heard about that? It's a new technology. It's actually been around for 10 years. It took probably 5 years for the FDA to finally approve it. Actually it's longer than that. Once they approved it, a lot of the facilities were started doing research on it, and then it was kind of released for general consumption, and people gobbled up these machines, but there was no CPT reimbursement code for it. So, and these machines cost about $600,000 a piece. So, and the private sector is going, well, this is a great marketing tool. We'll bring in patients for this tomosynthesis. And what they did was they could use the CPT code, which is a code that we use to be reimbursed, to get paid. There's the ICD codes for diagnostics, CPTs for payments. The CPT code, we could use it for diagnostic, and then we could charge the patient a little bit extra, and they would pay that in cash. And we just gave it as an option to patients. So they had a choice, and they could pay cash for extra. Now the CMS comes out and says in January, no, you now have tomosynthesis. You've made this huge capital investment. Now we're not going to allow you to charge any extra for Medicare patients. You're just going to have to eat that. Now you just spent $600 on new capital, and you're not going to get paid any more for that to recoup your costs. So what does that tell people who are thinking about getting tomosynthesis? Well, how are we going to pay for this if we can't make any? I mean, there is a business to medicine. We're not greedy animals. I'm not an animal. I'm a physician, but there is a business to it. So we can't take care of any patients if we can't keep our doors open. It's not to say that we're all in the poorhouse, but so the tomosynthesis, and now what else has it told manufacturers? People are going to build these machines, or who are currently investing in research and development to come up with new treatments and new medical devices, and I will disclose that I'm on the scientific advisory board for a breast biopsy device company, but that's not what I'm talking about right now. But the tomosynthesis, what it tells manufacturers and medical device companies is, well, be careful developing new technology that is going to help patients, because if there's not going to be a reimbursement for it, then nobody's going to buy it. So they're going to stop investing in research and development. They're going to stop building new technology. So we've just created a crash on innovation. There is overutilization, and I have a policy paper that talks about how we can fix that, and that's really for health reform, the state level. They're outside there if you're interested, and maybe we can talk about some of that. But I'm not saying there's underutilization by any stretch. The problem is that we've created a system where the person getting the care and the person giving the care are separated from the person paying for the care. Mm-hmm. And that's a huge problem. When somebody says, just go shopping and I'll just write a check, boy, you can bet I'm going to go to Saks. So that's the problem we've really got. That's a huge issue.
Thank you, Dr. Vecchio. Microphone number 2.
So I guess this question is for the gentleman in favor of the IPAB, kind of speaking a little bit to your point. It's sort of intuitive for most of us to know that, I guess Milton Friedman said that, no man spends another's dollars as wisely as he spends his own. And it would appear that if overutilization is the problem and people are receiving care that doesn't improve their health, I think that presumably the majority of consumers, if spending their own money, would be less likely to spend money on care that doesn't improve their lives. So if we were to just allow prices and consumers to choose what to spend their own dollars on in terms of healthcare, why would we rely on an administrative board to increase the transaction costs and lower prices when human beings making decisions for themselves would be likely to do that on their own? What is the justification of having an increased transaction costs and an administrative board to make that decision?
Let's see. Let me start with just a start. The fiduciary and paternalistic relationship of the physician to the patient, which is necessary in part because some of the decisions that need to be made in healthcare can't be made by a patient, especially not by an unconscious patient. But imagine me in a car accident. My daughter was in that car wreck this afternoon on I-25. She's right now in Swedish getting imaged. And I hope she comes out okay. Wow. So one of the questions, and she's pregnant. So they don't image her too hard. But
we have rules about those things.
Yeah, I know. So a couple extra limbs don't matter. The question for a brain image, a brain damaged or a spinal cord injury or acutely injured patient, unconscious patient, the dialogue I would have with their ghost would be, listen, I want to put a central line into you. There's several kinds of those, and there's different choices about that. Oh, and there's a way I could do a CT now with or without contrast. Some people say MRI is better, but a place across the street has even a better thing. We might want to put a tube into this, and I don't know if your spleen is ruptured. Now, here are the costs of those things, and there's pros and cons, and there's comparative effectiveness of each of those things, and we might be able to scrimp on the spleen thing if only we did a paracentesis. Oh, well, crap, there's different catheters for paracentesis. So we could have transparency at that time, but basically the fiduciary relationship says, the same thing, the same motivation you have that had you come to me because I'm making those decisions for you in absentia as your proxy, requires that long before we ever had to have that dialogue, we had to sit down with a smart bunch of people and say, look, when it happens, what do you want to do? Like, what is in the best interest of that particular kind of case, plus the case that's sort of like that? And that's why experts would sit down and premeditate it, okay? So the notion about at the time decision is really a fallacy. That's why markets don't work in healthcare, among other reasons.
That's time. That's time. Thank you. Microphone number 1.
This question's for Dr. Vecchio and Dr. VanderArk. I heard you mention the Federal Reserve Bank as sort of a model for the IPAB, in that it is in some type of oversight committee. But the Federal Reserve Bank is basically skirts right under Congress as well. And there's been a lot of documented fraud and kickbacks to Goldman Sachs executives on this. It seems to me like pharmaceutical companies and insurance companies are going to be very interested in the outcomes of some of these IPAB decisions. Do you think that it's feasible that the IPAB will remain independent, given that they are kind of on the same deal as the Federal Reserve Bank?
Yeah, it's all yours, Gary.
Absolutely. We have not in this country ever developed a system that cannot be tampered with, where fraud absolutely is not a possibility. And I think that really what it comes down to is comparing apples and oranges. And in this regard, do you want a bunch of healthcare experts, or do you want the Congress making these kind of financial decisions in healthcare? And my answer to that is, we've tried Congress and they have failed. We need a different system than we have now. And the beautiful thing about our transition in medicine is that we're going to move from volume to value. And I would think that during this transition of moving from volume to value, it'll be incredibly important to have a group of healthcare experts who are making financial decisions with regard to reimbursement.
Let me just chime in on that. It wasn't the Federal Reserve that was corrupt. It was the Securities and Exchange Commission that was corrupted.
Okay, we'll move back now to microphone number 2.
Just to tag along to the same question, back to you, competitive markets. Can you tell me who were on the iPad that developed the iPhone and all the technology that we've seen that has improved our lives? It sounds great in theory that 15 people can make these great decisions, but I'd rather have 317 million people making decisions every day about how they conduct their lives, and they have the right incentives. A panel of 15, I don't know who they are, and I don't know what incentives they would have. I think I'd like to hear a little bit of your ideas of where the incentives could be better applied in the healthcare industry.
Who's that for? Me?
Yes.
Well, my gosh. First of all, Paul Krugman, a Nobel Prize winning economist, and we know how valuable Nobel Prizes are these days. He says that there's no way to have a free market in healthcare. Well, first of all, we have to look at healthcare as two different markets. We have catastrophic healthcare. That's the healthcare that unfortunately Michael's daughter is experiencing right now, where she has to have some kind of insurance to be able to withstand a tremendous amount of diagnostic costs and imaging to take care of her when she's in crisis. But that is not the bulk of American healthcare. The bulk of American healthcare is made not under duress. But it can't be done freely because there's no pricing transparency. There's no way for patients to easily figure out what's going on in terms of what it's going to cost them to get care. Physicians don't even know what it costs to give care, partially because we're overwhelmed by these stupid ICD-9 codes, and we've divorced ourselves from the intrinsic fiduciary responsibility we have to our patients to be able to show them how to achieve the thank you moment, where we give them the value for what they're looking for and what they're paying us. I don't believe the government's very suited. I'm very suspicious of Washington and anybody in it. I think that the Federal Reserve hasn't done a great job because the value of the dollar has gone down progressively for the last century. It was stable for about 400 years since the German thaler at 29 grams of silver or so. And then it crashed when we started having floating currency. And the smartest people in the room manipulating our money. Okay, that's a corrupt system, unaccountable and unauditable. So any Ron Paul folks in here will understand what I'm talking about when we talk about just simply auditing these people. Well, there's no auditing capability for the IPAB. There's no way to figure out what they're doing. And they're not recallable. If they screw up, we can't bring them out after 2017. How do we achieve the iPhone moments? Well, I'm going to, in the interest of my time moderator, I'm just going to mention one word, Elizabeth Holm, Theranos, the inflection point of medicine this week, where she went out, dropped out of Stanford, spent 10 years developing a system that's going to now allow you to do 1,000 different bioassays off a raindrop full of blood off your fingertip, cut the cost of a CMP from about $300 on the ChargeMaster to $7. If you haven't looked up Theranos, you should look at it because she is going to radically change how we do laboratory work. It's now going to be achievable out of the free market, out of a Silicon Valley company, to get people what they need for cheap prices. That did not come out of the government. But if you look at her board of directors, she's ready to go to war with the government. She picked Henry Kissinger as one of them because she knows there are people coming after her.
That's fine.
Thank you so much. Back to microphone number 1.
This is for Dr. Vecchio. It seems to me that Dr. VanderArk is setting up 2 possible outcomes to solve cutting costs, either Congress or IPAB. It seems to me there must be an alternative, and I'd like to hear your opinion on what that could look like.
I'm glad you asked that. So it's either government or government, is that it? It's either Obamacare or universal health care or go back to the system we had before. And, wrong answer, thanks for playing. It doesn't, we need to think in the big creative mind that we've been talking about, let the American creativity loose on how to solve health care, give them the choices. And when we talk about, Dr. VanderArk also mentioned we need to move from volume to value. Well, yeah, we need to move from overutilization to a system where people can determine what their own value structure is and what choices they want to make based on that value structure as individuals, not the values of some unaccountable group of 15 smarties. Okay, so they're not going to know what our values are. They really aren't going to care that much about our values. And what are their values going to be? We're assuming that their values are going to be the same as ours. Your values aren't the same as mine. So why do we think that some group of bureaucrats in Washington, in the midst of the government that we already don't trust, that doesn't spend our money well, why do we think that these people are going to make decisions better than we are going to make for ourselves?
Thank you. Microphone 2.
My question to Drs. VanderArk and VanderArk is, what makes the members of the IPAB experts for people which they are considered to be divorced from? So they're in Washington somewhere, and if the people on this board, they're divorced from the local people who are part of the community in the doctor-patient relationship.
So repeat the question is, what makes these IPAB guys experts? Actually, and I'm going to add to that, is there a level, I guess you're begging the question, is there a level of expertise that's called for and that could actually help us if we inserted it right at that spot in the ecology? And so I'm going to say, yeah, I see it. I see that as a very fortuitous place, but certainly one of the things that we often confuse in these discussions about the locus of control is when is a decision made at the bedside, right, which clearly is not the place for even your partner who was on call last night, let alone you, and let alone the administrator of the hospital, let alone the HM HMO medical director, let alone Congress, or the Federal Reserve. So there are some people that should not be impacting you at the bedside. But on the other hand, that bedside person, as we've heard, is totally oblivious to the larger systemic questions about how do things work, what do they cost, and what's best. I am not in a position to evaluate 3D imaging of any part of the body. I just don't know. But I do know that if you guys were the IPAB, all of you sign up, the kind of question I would ask you to answer would be, take my 3D imager or my gizmo or my blood drop thingy, and how much should it cost? How much does it cost? Is it safer than the other thing I'm currently using? Does it offer a benefit to this kind of patient more than the other thing I'm currently using? Comparatively, would we be gladder about the outcomes? Has it been studied enough? Should we study it some more? Where should we apply it? Those kind of decisions have no business at the bedside, but they should be decided, guided, let's say, by a kind of panel that is familiar with evidence-based medicine, sort of like what the United States Preventative Services Task Force is supposed to do about deciding about merely preventive services. Let's say this would be like a UPSTF that was technologically evaluating the policy implications of certain tricks.
Thank you. In the interest of time, we will take the remaining 4 individuals who are at the microphones. Turning back now to microphone number 1.
Thank you. There seems to be some evidence that there's a different utilization in Medicare between wealthy Medicare recipients and poor Medicare recipients. And I'm wondering from both sides, what you think will happen if IPAB is introduced to poor Medicare recipients?
Well, my deep fear is that there's no definition of rationing. Okay, that's not actually my deepest fear. My deepest fear is it's unconstitutional. Okay, we're a nation of laws or a nation of chaos. That's it. The Federal Reserve is not a governmental agency. It's a quasi-independent business is what it is. So that's not, this is a governmental agency, right? Well, we can look at IPAB. We can talk about the term the Canadians use, socioeconomically non-viable. That's a term that was used for my best friend in medicine. He's a board-certified internist and emergency room doctor. His mom was in Toronto gardening at the age of 80. She had a precipitous failure of an aortic valve. She went to Canadian Hospital. My friend said, in the Cleveland Clinic, 150 miles across the lake there, we float percutaneous aortic valves every day. How about doing that here? We don't do that here. She's not socioeconomically viable at 80 years old. Well, my family lives to 95. We just don't do that here. Well, how about if I fly her over to Cleveland? You can do that. As soon as they found out she was leaving for Ontario, they stopped monitoring her. She dislodged her tube feeding. She flooded her lungs with tube feeding solution, died of Mendelssohn syndrome 5 days later. Okay, this is what happens when people who are divorced from direct patient care make dramatic decisions for people. Okay, it may well be, and I'm fully accepting of this as a federalist. I believe that the people of Massachusetts, that they want a single payer, should have it. But I believe strongly that the people of Idaho don't want that, and they want to have health savings accounts. That there shouldn't be some group of people at the government saying they can't do it. Okay, this country is built on experimentation, on innovation. That's how we end up with smartphones with more computing power than the entire Apollo launch system that anybody can afford. If we destroy that by having a wonkish group of technocrats sitting there saying, oh, wonder what the vested interest is of my job employment after this whole thing goes after. I was appointed by the president. It's not a recipe for success. I really like the idea of block granting funds from the federal government. I believe in taking Colorado money and putting it in Colorado. Why should Colorado money go to Ohio? It's not our money, it's your money. If you guys have a brilliant experiment that's working, you're profiting from that, then let us learn from it. Invest it wisely. Make the decisions you need for your elderly here, at the point of care, accountable to local people, with the best evidence. We have the best evidence. I can look it up right here, right? We don't need people in Washington telling us that.
That's fine.
Yep, thank you.
We don't pay any attention to the best evidence.
I do every day.
What we need to do as a group of physicians is to do SRs of CERs so that we have CPGs. Then we can influence IPAB to do what's right. What we're not doing now is systematic reviews of effectiveness research to develop clinical patient guidelines. We've got to, if we have guidelines, we can make this transition to evidence-based medicine. Then IPAB can make decisions that are appropriate for all of us.
Thank you. Microphone 2.
This is sort of a follow-up to my original question, but this time, I guess, for Dr. Fredericks. So the point was made that, I guess, our healthcare market is really healthcare ecology, and because it's laden with predators, coupled with, I guess, like a paternalistic physician-patient relationship, is it really still feasible then for prices to, I guess, enter into human decision-making when deciding like what they want for themselves, if they're forced to listen to a physician, or if there's all these predators out there seeking to take their money? And I guess my question is, like, what mechanism exists to protect patients from predators or from paternalistic physicians?
Yeah, I deeply like Michael's metaphor for that. It's actually illustrative, and it's nice to look at it that way. But again, you can risk oversimplification of the healthcare market. There are two healthcare markets. There's the market that's done under duress, which is actually a very small number of people that experience that. And then there's the market that's elective. Okay? That market still exists. There's plenty of fee-for-service models, people opting out of third party, people practicing independently that have the fiduciary and ethical responsibility, in contradistinction to what Gary's saying, of learning best practices and looking at what works and making decisions with their patients. It is automatically a paternalistic relationship unless I'm dealing with another physician. And I go to an internist, and my first words to my internist were, Jim, you tell me what to do. I'm your patient. I'll listen to you. A doctor that treats himself has a fool for a patient, okay? I ask him informed questions, but I actually act in the same fashion. So, but the problem is it's been a one-size-fits-all program. The whole thing is a one-size-fits-all program. It doesn't allow HSAs, doesn't allow mutual aid societies, it doesn't allow the flexibility of lots of choices in a market to find out what works best for everyone. And therefore, it's very difficult. And until we get pricing transparency, until people can go up and say, what does University of Colorado Children's Hospital charge for an appendectomy, average, versus the hospital down the street? And why do they charge $10,000 less just across town? I guarantee you're going to find some disparities in some coding on that, because we do it in Columbus. Until we have that access, doctors can't even inform their patients, right? They don't address any of that in the government. They just say, oh, we'll make the decision for you. How about telling us what it costs? Making people who take Medicare and Medicaid broadcast on the internet, this is what we charge for elective surgery.
Amen.
Yeah.
Thank you.
We agree about something.
Of course we agree on that.
Very good. Seeing agreement, we'll move back down to microphone number 1.
We can fix
So this actually segues very nicely into my question, which is for our defenders of IPAB here. We have some wonderful examples of price, transparency, of, competition, and of cost control coming in with groups like Alliance in Portland, where you can get primary care for about the cost of a cell phone plan. Like the Surgery Center of Oklahoma, where their total charges for surgery plus anesthesia plus facility are less than what Medicare pays to the hospital down the street. And these things have happened in spite of government. So why is the solution to cost control in Medicare then to double down on the coercive power of the state instead of to resort to the market when we've seen that it already works?
Well, I guess we have to deal with that because you threw it at us, but it does. I love the coercive power of the state. I was a medical director for a commercial health plan, and I went around and talked to highly corrupt doctors and healthcare systems about their pricing. The problem with the ecology is you could always point to one little flower that's doing well and thriving in a niche. But if you look, your patient isn't going there. Your patient is going somewhere else. And there's a snake oil salesman around the corner that's selling some high-priced garbage to your patient that's got Chinese lead inside of it. And so there do need to, the coercive power of the state, which I would call policing power of the state, is what I want that helps keep some poisons and toxins out of my relationship with my doctor. The doctor can't detect, I can't detect it. We really need to have a surveillance system that helps to level it. Now, hopefully the surveillance system is not run by idiots and they're not corrupt. So when we see something that's working over here, just like that machine there does, it can say, hey, did you hear about the thing? They've got 3D imaging of your blood now. This is helpful. Look at those red cells. But that isn't necessarily coercion. That's the science process, which I would sort of say is the buffer inside between you will do this right or wrong, or I'm going to have you recommend this to you right or wrong.
Thank you. Microphone number 2.
Thank you, and this is for those that are defending the IPAB. My name is Kim Munson, and inherently when we were kids on the playground, we had principles, kind of American principles, that we get to make the choices about our own life. And that we'd say, you're not the boss of me, it's the principle of the thing, or make me. Well, it seems like the IPAB goes directly against that. You have 15 people that are paid $165,000 a year each to make decisions for 313 million people in America. How will we prevent those 15 people from being corrupted?
Remember, the president's going to appoint them, so they'll only appoint good ones. And for $165,000, it's not worth it to not be honest. I mean, it's like that. Never mind. Here's one answer for you. How can 5 engineers building a bridge make a decision for all the people that live in the valley underneath it? You would think the people in the valley should be able to come up with how to design a bridge. And why do we need someone who understands concrete? And so it isn't that I foresee that each of those 15 persons is going to be trying to decide whether or not I get a subclavian on the left or the right. That isn't where their job will be located. If their locus of control, though, is in keeping really toxic, bad concrete from going into bridges, then the people down below will never know it even happened. And it isn't an infringement on their liberty. It's an infringement on the organization that would like to kill them.
Can I make a comment about that? Yeah, is that possible? Can I do that?
Actually, I was going to say Dr. Vecchio has not had a chance to speak as much as the others, so I was actually going to allow her one more rebuttal.
If she's supporting me, let her talk.
Yeah. We're making it, my colleagues are making it sound like it's going to be an absolute free-for-all if we don't have government in charge of all these decisions. And that's just not the case. We're not saying get rid of the FDA, get rid of all regulation in healthcare, allow pharmaceutical companies to just run amok and put poison in all our pills. That's ludicrous. And that's kind of what I'm getting the impression that he's saying. That's not the case at all. What we're saying is we don't need more government in these decisions. We need less. Allow us the freedom to make those choices.
Excellent. Well, our debate is drawn to a close. Let's have a round of applause for our debate. So we're now going to roll into our final voting tally, and I'm going to turn the microphone back over to Bill.
Thank you. Wow, I had a great time. I hope everyone else did. I'm sorry, Dr. Vecchio. We're only about 20 minutes over time, though. But we're doing great. We're right on schedule, right? So thank you for coming out. Please be safe going home. Please keep Dr. Victoroff's family in your thoughts and prayers. And thank you so much for coming here tonight. So I think we're passing the sheets around to the left. We can post them on the results on BRI's website if you have to go. I will tell you that it doesn't look like we captured everyone when they walked in, but most everyone ranged from some to nothing for their knowledge about the IPAB, which is great. So you didn't come in knowing very much. And pretty much everybody said they don't know as to the question of is it the way to control Medicare spending. So maybe you were able to formulate some opinions, and gosh, thank you so much for coming out. I appreciate it. Thank you.